Welcome to today's webinar on 10 troubling truths about the tibial plateau leveling osteotomy. And I am Dr. Narda Robinson, founder and CEO of CuraCore Vet and CuraCore Med. So yeah, the tibial plateau leveling osteotomy, that's what is the TPLO, and that's what we're going to go into. And for the 10 troubling things, lo and behold, there are so many ideas to choose from that we can make it into a couple words like the tragic TPLO. I usually say the dreaded TPLO, but this time I'm going to say tragic because dreaded had too many letters. So, but we'll also be talking about alternatives. Okay, so your first impressions when you see a lame dog. Here, this dog doesn't look real happy, looks like maybe a stray. And so, the way that we are cultivated to think in veterinary school is okay, must be a cruciate, and then there's just boom, boom, boom over to TPLO right away. So, somebody says, what's your diagnosis? Oh, well, it's cruciate ligament injury till proven otherwise. What's the treatment? TPLO till proven otherwise. What's standard of care? Well, TPLO, like I said, or maybe there's something else, but first you got to do surgery. So, um, some might think, is this even an issue? Because they think, okay, it's signed, sealed, and delivered. This is how we do things. And my goal today is to show you that there are other ways around this and perhaps more preferable. So, even in the human field, there are debates. And so, this is a little bit of tissue being formed to serve as a surrogate cruciate ligament. And in this article, anterior cruciate ligament tear is conservative or surgical treatment, a critical review of the literature. And just showing you that in the human field, and it hasn't really changed much since this article was written and published, they say at present there are no evidence based arguments to recommend a systematic surgical reconstruction to any patient who tore his or her ACL. Knee stability can be improved not only by surgery but also by neuromuscular rehabilitation. So that's something that we can remember as we're moving forward here, that despite what the groupthink is in veterinary medicine, that there's a whole world of treatments out there that do not involve cutting and repasting or replating a piece of bone. And that's by educating the nervous system, the muscular system, the fascia, and just that whole neuromyofascial web. So, whatever the treatment, fully normal knee kinematics are not restored. And when we go through here and look at what the TPLO involves, for those of you that are maybe clients, so not veterinarians, if you haven't even known about this, but you're convinced the TPLO is what your dog should have, you'll see that if we link structure and function, which are just inextricably intertwined, that there's no way that you can have normal kinematics of the stifle once you reposition all the bone interrelationships there. And they continue. While the patients wish to go back to their sport and want everything possible done to prolong their activity, their ability to perform these activities, they should be informed that the risk of further knee lesions and osteoarthritis remains high, whatever the treatment, surgical or conservative. So, as we go through our courses, whether it's our integrative rehab program or medical acupuncture or all of the above, because really what we like to promote is a multimodal, multidisciplinary, non surgical support and cultivation of the restoration of health and that sensory motor integration. So, how can I justify non surgical methods of treatment to my colleagues and clients? Because there is a level of intimidation there, especially when you have so much of the profession and those that teach in schools caught up in this TPLO is the gold standard idea. So, how do we approach it? Well, with science, with evidence, and being transparent to clients and ourselves and our colleagues about the benefits versus the risks, and to realize there is no reason to rush into surgery. And since I've been writing about the TPLO and its issues, and I'll show you a couple of links to what I've written, like where I first got started really being vocal about it back in 2012, that I would be contacted by people, even in Europe, who would tell me very similar stories that they were being encouraged to pursue surgery ASAP, or this dog's going to get disabling arthritis and it's going to be your fault, and you better start saving for the next one because here we got one, the other is going to go as well. And they get scared and confused, and they don't even know, I believe, all of the potential complications at hand. And there are a lot. And it's no fun being surprised with a dog that has serious, unstoppable infection. And we'll show you some of that too. So we should all just, whatever we're doing, science and evidence and risks versus benefits, and let the clients decide once they are fully informed. But this cultivation of a mindset to accept and promote the TPLO begins in veterinary school if you're becoming a veterinarian, and it doesn't let up. So, as students and clinicians in training, and even as vets in CE courses, typically, what are we taught to see? So here is a quote from the American College of Veterinary Surgeons. It says, rupture of the cranial cruciate ligament is one of the most common reasons for hind limb lameness, pain, and subsequent knee arthritis. So when I showed you that picture of the lame dog, and I talked about the stimulus response, typical typical idea that, oh, dog is lifting up the limb, it's cruciate ligament till proven otherwise. I mean, you even hear that in some continuing ed programs, that people will repeat just those words, and it's just out there, and I think it's shocking. But do you get encouraged to think critically, to think about differentials, and whether or not there is a cruciate ligament injury, what else might be going on, or what else might it be? So, with the tunnel vision, and this applies across the board to whatever condition we're looking at, and get used to assuming is something so that we can fit it into our little compartments. Because let's say we learned for a given area of the body, we typically have 10 of the most common things that happen. Then over time, if you're not working your mind and your synapses, you tend to think, okay, I got to put it in one of these boxes. Where will it fit so I can go on to the next patient, especially if you're working in a practice, you don't have much time and you just want to move on with things. So it's a real risk. And what that type of practice encourages you to not even think about are the potential myofascial trigger points that could be causing the lameness, and the restriction that that entails, and how far that goes all over the body. Referred pain, which we'll get back to, the balance of the agonists and antagonists in that pelvic limb, and how they have to be balanced to give that little piece of ligament tissue enough support so that we have the integrity of the stifle joint, not relying just on this little piece of tissue, but on the whole body and the nervous system and the muscles and the fascia. So there's so much more that we can think about. And typically, based on the responses to my quiz questions in my courses, pretty much nobody as of yet has said to me that they learned about nerve entrapment in veterinary school. There's so many places that these soft, vulnerable structures can get squished and get subject to a relative anoxia, or just that constant pressure. It makes them very unhappy, and then when they don't have the proper blood supply, and they're always getting just rubbed on or whatever, they are not going to fire well. And if your nerves aren't firing well, you are going to be missing out on joint integrity. So then that leads to sensory motor disturbances. What signs do we expect to see? Okay, so back to the American College of Veterinary Surgeons website. that they have for clients saying, okay, does your dog do any of this? Probably you should bring them in and we should do a TPLO. And, it's not just like, let's do a blood draw. This is a huge, expensive procedure, and depending on whether you're in the U.S. or Canada, I hear prices from 5,000 to even up to 15,000. Of course, the Canadian dollar is different, but it's very, very expensive. And especially nowadays, people are losing their jobs; they just don't have a capacity to pay, and yet they love their animal, and they will do whatever the vet that they trust so very much will tell them to do. And I think we should be giving them other options and routinely and lots of other options. So this website says, does your dog have difficulty rising from a sit, trouble jumping into the car? Any of these, you can read them yourself. Decreased range of motion of the knee joint, a popping noise, swelling on the inside of the shin bone, tibia, pain, unwillingness to play, and stiffness. I mean, some of these could sort of be a cruciate thing. You could have that constellation of signs, but you could also have a lot of other things here as well. So it's like, let's just catch them all and get them in, and we'll work on that cruciate. And so let's say they have a little ligamentous laxity and they have those other things. They're on the freight train into the surgery suite pretty soon. So what else might be causing this dog's lameness that we looked at earlier? Could be stifle pain from something non-cranial cruciate related. Could be hip pain referring down to the stifle, and these trigger point pain patterns that we'll take a look at. And again, nerve entrapment, aberrant muscle firing, reversible strain or sprain, any number of things, but that's just probably a good selection right there to think about. And I'm not sure if this will play, but this is a video from one of our courses, and this dog has bilateral cruciate ligament disease diagnosis. But I want you to see, and this is what we practice in our courses as well, just like with radiology, that don't just, if I say that there's chronic cruciate there, as has been diagnosed by somebody else, and this dog just comes in to participate and volunteer in our courses, then you're looking here. But what about you're looking everywhere else? And I haven't even played the video yet. So what muscle on this dog's body is of normal length, a nice relaxed length, and is not shortened? Where is the fascia really friendly and comfortable and everything? Is it the tail? No, tail doesn't look so well. What about the sacrocaudal junction? Is that normal? Is the hair coat normal? What happens here? What happens here? And sorry if there's a delay as you're watching this, but we look at how the fascia is battening down that skin, and so the hair, the dermis, then we get into the hypodermis. And so between that hypodermis, or that more superficial layer of fascia, to the fascia profunda, which is overlying the muscles here. I mean, sometimes that can get all sticky just because of this chronic inflammation and injury. And certainly we see that here with the smoothness, the tightness looking here. So yeah, there's a lot of tightness there. And then is the back normal? That looks kind of bunched up. What about the neck? Looks shortened. If there's chronic pain and lameness in the back end, then of course is going to be shifting here. You can just see how thick the shoulders look, and then it's going to go up to the neck and head, and maybe we can see the face here if we kind of turn around. So here Jess is working with the dog and doing some sits and stands, and certainly the dog is motivated for treats. But if we look anywhere, still the mechanics aren't well, and whether there was surgery or not, these are not normal kinematics. And then it goes into a myofascial exam after that, but that takes quite a bit. But on this dog as well, there would have been a medial buttress sign. And so here, it's just, again, exposing this groupthink issue from today's veterinary practice in 2013. Canine cranial cruciate, lots of C's and R's, canine cranial cruciate disease. We need a little bouncing ball. Canine cranial cruciate disease, canine cranial cruciate disease. Updating our knowledge about pathogenesis and diagnosis. Okay, cool. All veterinarians should learn and recognize the appearance of the medial buttress sign. We love the medial buttress. Shortly after cranial cruciate ligament rupture, most, if not all, patients develop a distinct firm swelling over the proximal medial tibia in the region of insertion of the medial collateral ligament. Cool. We can agree on that. Okay. It's a reliable sign of cranial cruciate rupture. Well, okay, maybe some laxity there occurs rapidly after ligament rupture in most dogs, provides ample indication for surgical joint exploration, even in the absence of a cranial draw sign. So, okay, you have a medial buttress because your system, your inborn system is working well and providing calcification for some ligamentous laxity. And now you're stable. You don't need surgery. No, you don't. You don't need surgery. But yet, who's being told to send them? Yeah, let's just get into that joint and see what's going on. Why? Why? Right? This is a buttressed wall. Looks pretty stable here. Are you going to take away those bricks and look inside just to see what's going on? Is that going to make things any more stable? I think not. Okay. So, what is a TPLO and why is it such a big deal? At least to me. Okay, well, here we go. So, cut and plate. I said cut and paste before. This is a little bit like that. Cut and plate. And this was an article from the World, blah, 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 Sava in 2004. And just you can see here in the circle that you just take a saw and you cut that bone and then rotate it because Slocum's dad, I guess, was a human orthopedic surgeon. And, just pondering, looking at things, is like, well, okay, there were other procedures around, but maybe what we could do is just cut the bone in part. And who cares if orthopedic surgery is the most painful type of surgery there is? Let's revise the dog's limb so that it looks more like the human. So, when we go through the tragic TPLO, the 10 top troubling things in the TPLO, number one is T for trauma, T for traumatic. It's traumatic for the dog, for the person who's bringing the dog in because they're getting a big bill and they're getting a dog that's going to be very painful, and then the vet who hears dogs howling after surgery and or handles complications. And the TPLO was the reason why I stopped, for the most part, whenever I could, when I was at the university. I stopped going into the critical care unit because I could not handle hearing those dogs in pain after TPLO surgery. And yeah, you can do all kinds of different types of pain control. There are all these articles coming out about managing pain after TPLO. It shows you how terribly painful it is. You are sawing a bone and plating it, not to mention all the other stuff that has gone on with that animal, with the peripheral and central sensitization for having whatever problems that dog has. And maybe they have a neurologic problem anyway, and it wasn't even mainly the cruciate, but they got a TPLO. One of my friends just yesterday talked about a dog that got two TPLOs, and there was actually a gastrocnemius rupture. So misdiagnoses happen, and then who's paying for it? The dog and the client. So I have a little story here for you, a little fairy tale, but it's real. So once upon a time, when dogs became lame, and before doggy rehab, and medical acupuncture as we know it today, and photomedicine and medical massage, and even herbal medicine with a little drop of CBD right there. Before those became, more popular and available and taught scientifically, if dogs had surgery for cruciate ligament injury, it did not involve carving apart bones. But then came the TPLO, invented by Dr. Barclay Slocum in the 1990s. And that's when things changed, as I showed you earlier, that there goes the saw and there goes the integrity of the tibia. Because why work to rehabilitate tissues when you can blow the top off of a mountain or just remodel the landscape if it's a dog? And why not? You're richly rewarded. Is there no incentive there? And that's our rewards. What's more, From the specialists that often dismiss or try to dismiss integrative medicine due to their incorrect, not all of them, some are very informed, blah, blah, blah. But the ones that come to my lectures when they know I am speaking about the TPLO, and they come out there specifically to sit there and be ready with their typical questions at the end and their double-blind placebo-controlled studies. It's like, yeah, you're doing placebo-controlled surgery studies. Tell me about that. Why don't you? Show me your publications. Anyway, they like to dismiss integrative medicine, and I like them to do that because I can then inform them, but they have incorrect perceptions. But when we're talking lack of evidence, let's look at the origination of the TPLO. And this is from Veterinary Partner. It's associated with VIN. And this Greg Harrison writes, whereas the age-old procedure in medical research has been that when a new technique is developed, it is published in a scientific publication and presented at scholarly meetings to allow one's peers to scrutinize the information. But that's not how Slocum did it. Instead, he patented the procedure and the equipment used to perform it. His scholarly writings and lectures were short on specific details, and he spent a good portion of the later part of his career teaching the procedure out of his veterinary practice. Further, those he taught were required to sign contracts that they would not teach or publish details of the procedure to others. So it's just like we're going to be covering Chinese herbs in the future, and when you keep your secret herbal formulation, to yourself, and it's manufacturer's secret, it's proprietary. I mean, that's bad enough, but you have here a surgery. You are carving apart a dog's tibia and not allowing it to be scrutinized, and we're okay with that? To call the reaction to this approach a firestorm within the veterinary community would not be an overstatement. The views of many concerning Slocum and the TPLO are colored by the controversy to this day. Well, to tell you the truth, I have not seen that. It seems like TPLO is regarded or hailed as the gold standard, and I don't see much critical questioning of it. Dr. Slocum passed away in 2000. His death had many important impacts on the TPLO. First, the patents expired, and people could teach it. They could do independent research. They developed their own little nuances on things and variations and their own other techniques. So, what that tells to me is that there's lots of variability, and we have a gamut of practitioners, some of which are board certified orthopedic surgeons, and some of whom are general practitioners or whatever else, and all that in between. And studies tend to show that the more surgical experience you have, i.e., if you're a boarded surgeon, your results are going to be better within the framework of what you get out of a TPLO, which many people think is just wonderful. And I think you may be under assessing your patients, but that's just me. So we had the traumatic, we had the rewards, and here's the A for tragic. Assess the anatomy. Too often the diagnosis is wrong and needless surgery is performed. So wrong or incomplete. Here, you don't get these kinds of diagrams in the dog. So for those of you that aren't into primates, I'm sorry, but there's a lot of knee here that is where it's more than the cruciate, but all this stuff that you see is important in stabilizing the knee. There are particularly important places like this pes anserinus, which I've learned recently is only your superficial pes anserine. As though I didn't love the pes anserine enough, I just learned within the past week there is another one. There's a profundus pes anserinus. And I'm going to keep that to myself as to what that is until you come to one of my courses. But anyway, no, I shouldn't be that untransparent. But for the relevance of this, we will talk about the superficial pes anserinus. But look, you have quadriceps that are going to be working on the knee mechanics. You have all these different nerves and vessels that are going to feed it. You have these nerves here that are more on display here. You have the tibial nerve, you have the common fibular nerve, which are both branches of the sciatic, and you have the hamstrings, which are agonists to the cranial cruciate ligament. So if we talk about the agonist-antagonist balance, if you have overactive quads and underactive hamstrings, then you are pulling that tibia forward and you are antagonizing that effect of the cruciate in terms of holding it back. So the cruciate, again, it's just this little piece of tissue. And here's a cross section from my book. And this was from Stomach 35 Acupuncture Point. That cranial cruciate or anterior cruciate in the human is right in here, way deep. And yeah, things can happen to it. But do we need to separate the tibia and plate it in a different format so that we can stabilize the knee? And it's not even really a stabilizing procedure. It's just you're re-angling things so that not supposed to slip off, but it's really not that stable. I think what stabilizes it after surgery is all the swelling that happens. And then once you are done assessing the tissues related to the knee joint or the stifle, you should keep in mind that the source of pain that that patient is experiencing may actually be coming from outside of the knee. And that's where the referred pain comes from. And if we see what's been known about trigger points in the human, so these areas of continually shortened muscle, so you have a place here in the rectus femoris where if you strum it, it's going to feel really ropey. And if you press it or if you're strumming it, it may issue pain down the anterior or cranial aspect of the femur or your thigh and into the knee. So you can mistake you can think you have knee pain, but it's really a trigger point from one of your quads. And that's where this trigger point gets a nickname called two joint puzzler because it makes the examiner confused about whether you might have even hip pain or knee pain. I'm just including here trigger points from muscles that are sending referred pain into the anterior or cranial knee. Then we have the vastus intermedius, which is right below the rectus femoris, which was removed here, and that will also send pain into the knee. And that's called a frustrator because it's hard to palpate. It's often hard to remember to evaluate it, and it's tricky to treat. I use pretty long acupuncture needles when I treat that in the human. And then there's the vastus medialis that also has these X's, these trigger points that will issue pain to the knee. And also its nickname is buckling knee muscle. It's like when your knee gives out, yeah, that isn't necessarily that your knee is unstable, or it could be that your knee is relatively unstable because your biomechanics aren't working, your nerves and your muscles aren't firing correctly. So yeah, acupuncture is one way to deactivate certain trigger points to restore good somatic afferent stimulation going to the spinal cord and brain and treating it specifically and appropriately. We can also have issues with entrapped nerves, as I said earlier. And if the nerves aren't causing the muscles to fire appropriately, then those muscles cannot protect the joints and stabilize them because you can see how the knee joint is just femur on the tibia with some strings attached. And so those big heavy movers of the knee are so well equipped to keep things in place. We should not just be so focused on the poor little cruciate because many people, I mean, I'm hypermobile. If I do not use my muscles enough, then my knees become unstable, but I do not want a TPLO. So, how nerves affect joint stability. They can cause pelvic limb lameness through the incoordination, as I just mentioned. They can be hyper-irritable, especially after surgery. You're disrupting the mechanoreceptor input, you're cutting nerves, and the pain from, even if you don't have surgery, if there's nociceptive stimulation, you can get inhibition of mechanoreceptor firing and also motor use. And so you become unstable because the nerves aren't linking all these impulses and controlling outputs. You can get peripheral sensitization, so a change in the physiology of the peripheral nerves, central sensitization affecting your brain and spinal cord, and autonomic destabilization, which in essence will be causing potentially vascular engorgement and knee swelling, or it's just an epiphenomenon of that. So, what nerves will get entrapped in the lower extremity? And you tell me you haven't learned about this in school? Yeah, you haven't, but you should, because these are, if you were in an anatomy class, you could probably not even list all these nerves. All these nerves have areas that muscles can impinge on them. And so it behooves us to be doing our myofascial evaluation from nose to tail and top to toe so that we can see what is going on with our patient. And it's usually not just one thing, but if you're going to work for a practice and you have 5 minutes again, or maybe 10 minutes, or you never learned this stuff or whatever, you're going to miss a lot of stuff. So do not miss this, though, the pes anserinus superficialis. This is such an incredible sight. Here you have three tendons coming together. So you have the sartorius tendon. Here's the top one. Again, this is from my book, and that is going to the hip. And that is going to be giving the central nervous system input about what is coming, what what localization, what stabilization is all needing to happen from the anterior or the cranial aspect of the pelvis down to the knee. So you have the sartorius supplied by the femoral nerve coming right down here. You have your gracilis muscle, which is here, this slender little muscle here, coming down next to it. And that is providing the nervous system information about the medial aspect of the limb and up to that bottom or medial area of the pelvis. And then you have the semitendinosus tendon here, which is coming, it's attaching from the ischial tuberosity. So you have information from mechanoreceptors, if you look at that whole muscle, from the ischial tuberosity down the back of the thigh and then down to the knee. So you have this anatomical structure that is telling you encyclopedias about about where all coordination and forces and force transmission and maybe glitches or whatever, where all that's happening. You can think of like a figure skater that is going around and twirling and everything. That the knee that that skater is using to stabilize and to be all artistic and everything, that knee needs to be sending and receiving information from the front of the hip, the back, pelvis, the back, and then just the medial aspects. It's really important. And so we also know that tendons are conveying a huge amount of mechanoreceptor information. Again, with medical and veterinary education, typically the main time you hear about tendons is you're either going to take them off somewhere or you want to anti-inflame them. It's not about adjusting their mechanoreceptor status so that they can better do what they do, and with the nerves involved in a tendon, support the homeostasis and tissue regulation and metabolism of that tendon so it can do its thing, because it's under a lot of stress and strain with that muscle pulling on it all the time. But pes anserinus means goosefoot, and that's because this area here, when you haven't removed the fascia, and this is just a computer regenerated image from the Visible Human Anatomy database, but in situ, in the real in person and animal, there's a web of fascia that looks like a goosefoot because of the webbing that's containing them all and helping to facilitate communication. So it's not just that these three muscles with three different nerves, the femoral, the obturator, and the tibial branch of the sciatic. They're all coming here, conveying information that's going all over the pelvis and using that importantly. But they're also being contained within a fascial structure that is helping to promote unity. And so it's a great area to know about. It's really important to palpate, and I regard this as a harbinger of potential cruciate issues, so that when you palpate tenderness here in dogs, that you need to attend to that, because something is speaking there and there's no nociceptors or something. There's some tenderness, something's going on there. So how about we're seeing our patients and we're finding that because we're looking for it and we're saying, you know what, I'm going to pop in spleen 9. If I'm an acupuncturist, I'm going to pop in spleen 9. I might even, as a laser therapist, I'm going to do some not heavy duty burny type of laser, but we're going to do some nice laser there. So very, very important site. And and that's not all. And then you can have this saphenous nerve here. You see that L2 through 4. It's one of the branches of the femoral nerve that's coming out here. There can be saphenous nerve entrapment right here that is also provoking tenderness to palpation. And that poor little saphenous nerve, yeah, okay, it's just a sensory branch. But look at all the structures in here. Look at all this neurovascular supply. This is all important stuff for the integrity of movement and the coordination and the reconstruction in a nice natural way and repair, so that when things are going awry, that if we know about all these different tissues and the joint capsule and the menisci and the ligaments, if we know how to work with them appropriately using acupuncture and laser therapy or LEDs and massage and appropriate botanicals, then we have this huge huge repertoire that we can give to this patient to help repair, ideally early. And yet, what do we do when we have a TPLO? We move those tissues around, we cut into the bone. That integrity is demolished. But yet, TPLO, the gold standard. And that information gets out, that you see that all over, and you see vets, vet students, a lot of people repeating that. You even see within the rehab community, you know, it seems to me that too often rehabilitators are happy to sit back and be the post-surgical rehabilitators. And that's just not right. When I say rehab, I'm meaning rehab after an injury, not after surgery, though that's important too if they do get surgery. But surgeons have the loudest megaphone. And part of what these webinars are about is to give voice to the science and evidence and opportunities for treatment with less invasive means, so that clients and vet students, all this stuff, that it can get out there, because otherwise we're in an echo chamber. And it's good to tell the surgeons a little bit about what we do. Oh, which I did in in 2012. Questioning canine cruciate ligament surgery. Yeah, what the hey? I had already been writing for Veterinary Practice News for 10 years. So, and I'd, been where I was for a good long time. So I just figured this would be a good thing to write. And I went through 8 claims why saying that surgery is the best option for your dog is false. And needless to say, that was not so well received. And you can see here a year later that um, I was invited to put together with the surgeons a document like this, and we had it published in the Veterinary Practice News. I think it's also on the CSU site. Why you could have surgery, or you could have non-surgery, and you got to make the decision for your, it's all good. There's just a lot of options. Then a few years later, they came back and wanted to interview me from Veterinary Practice News, and it's like, yeah, why you should consider non-surgical care. Just don't try and tell her that surgery is the gold standard for treating cranial cruciate ligament disease. I didn't write this, but I was interviewed for it. The time has passed, and now we see, surgeons who are in rehab as well, talking about conservative or medical or non-surgical treatment. And so there is progress made, most definitely, and that's a good thing. So when we talk about TPLO gold standard, are we being honest about the surgical risks? So that brings us to inflammation and infection in the word tragic. So here's a tragic story, and this is from a veterinarian that has been through our program, and it it shows how you can be a vet, you can be quite accomplished, you're you're excellent in whatever field you're doing, and yet when your animal gets sick and you are relying on others to tell you what to do, even if you feel that that's not the right way, we can all be subject to being railroaded into things. We're weakened, we don't necessarily know other options ourselves, and we are relying on other people to tell us what the best way forward is. And when you have a profession that is so widely compelled to believe that TPLO is the be all and end all, you don't maybe have many resources. And I see this when I speak at other schools sometimes, and the vet students who have dogs with issues, they're in an integrated medicine club, so they want to have other options, but they've been dissuaded sometimes from the surgeon. And it's like, you need to have surgery that they say, and I say, you need to think about this. And so anyway, but this is a radiograph of a post TPLO, and you can see that curve, that saw cut and reposition of the top of the tibia and the plating, which causes problems, as we'll see. So so this vet wrote to me, and she knew that I was not an aficionado of the TPLO. And here's her story. My dog is a now 8-year-old American Bulldog who partially tore or has had cruciate disease since 6 months of age, but he also needed shoulder OCD surgery at the time. I was actually told that he needed bilateral TPLO at 6 months of age. WTF? Who who cuts into baby bones? So I said no. So she went on, and he did well. He had done underwater treadmill, laser, Dasequin, Adequan, CBD as needed, and she was keeping him lean and active for years. And then, after quite a long time, he had sprinted in the yard, and she could just not get him sound. She debated for about 3 months, went to two surgeons, one who was offended by vet mom's dog's hair on his pants. And so then she decided on having the local university perform a TPLO. Nico, who's her dog, and I guess a lot of bully breeds never just fully tear, just stretch their ligaments. His was stretched and his tibia was rubbing on his femur, but he had no meniscal tear. So she stayed at the university for 3 days, and no, Nico did, and had immediate rehab there and at home. And then he had a painful day on the day 8. She took him back, but then he seemed fine. By day 15 post-op, his leg swelled up and he was on a wound vacuum in the ICU with intravenous fluids, 105-degree fever, to pull purulent debris from his wound for 5 days. Multiple bandage changes, cultures every 2 days. Total of 9 days in the intensive care unit, and he lost 13 pounds. The wound was closed, but it still had a light growth of staph. Culture was not finalized. Went home for less than a week when she had to go and have it opened up again. She was out of money for more, care, and her credit card was on fire. She said, I did my best to care for him at home. Tried amikacin injections, flushing, blue light, so photomedicine, a magnetic wet bandage, ended up using bleach, yes, bleach. Then in the end, after a total of 5 months of wet bandaging, sedation every 2 to 3 days, lots of tears, the fracture and cut line had finally healed and the plate could be removed. Amikacin beads at the end, and they were removed 3 days later for a final sedation. And she says, what a long year. Makes it hard for me to ever recommend a TPLO. Last year totally sucked as I was trying to keep my dog alive and hardly got any downtime from work and caring for him. And then she said, I'll send you a happy pic of him too, her orthopedic lemon. After all of this, his scar was super tender and he was so muscle wasted. And then she talks about CBD oil with gabapentin and meloxicam, and he does okay with those. CBD seems to help his hyperpathia, and he had liver issues from the amikacin, and he hates laser because his scar is the size of Texas, and he doesn't really let me touch him on this leg still. Reflecting on this, she says, I said no to the TPLO for years. I regret this decision a lot. My dog has minimal improvement in his gait, has chronic pain, seems like hyperpathia to the incision. Again, Nico's tibia does not rub on his femur anymore, but he is still pretty screwed up. So this is a vet who resisted and didn't have other options. I am not sure I would do what I did again. Just so much guilt for putting my dog through a procedure I said I would never do. And that's Nico. Tolerates the Azizi loop, but not if it touches anything. Cost of surgery, $18,000. So your best price is just that initial thing. It doesn't talk about the follow-ups, doesn't talk about replating, fixing the brakes, infection. She said, I know I have told people that when a TPLO goes bad, it goes really bad. I don't think I could have imagined what my dog went through. I don't think I realized what a biofilm truly was until last year. I do feel like some complications are mentioned, but nobody mentioned it to me that your dog may need to have his plate or leg removed if the infection sets in. I do feel that complications were minimized. And that's what they tried first is a silver impregnated calcium alginate, really expensive thing there, soaking up infection, yet there would always be a biofilm underneath that on top of the plate. So that's when they went back to the university and she got the culture and sensitivity. And the only thing it was sensitive to was amikacin. And she talked to the university microbiologist who said she was not surprised by my dog's infection. She's always been helpful with referred cases. Her comment was that surgeons can't expect to do that much manipulation to tissue without significant risk of infection. I wanted to vomit. I thought to myself, what is the true rate of surgical infection? And the reported rate is quite high already. But what's the true rate? Because how many of these get reported by a university researcher? It isn't the few percent that's reported. And she showed this picture. This is the night before I went back to the university. Initially, I was told my dog was just using his leg and had too much swelling. And yet, that's what was going on. And there he is in the intensive care unit. And that is the surgical site 1 year later. So, reflections later on with other clients. I did have an older client reach out recently for acupuncture consultation with a dog that was 3-legged, 35 pounds, not a big dog. When asked what happened to his leg, he lost it from complications from a TPLO with the fracture, the infection, and then the amputation. Again, I know they were not prepared either. All that pain, expense, trauma, and exhaustion, and not prepared, not offered non surgical alternatives. And that's the key. If you thought, okay, I will do TPLO if everything else fails, or you were given the option, yeah, which I would not refer for TPLO personally, but let's say it was out there and you can always do it. It's not an emergency. You have time. You can wait till that trigger point it gets fixed and that dog is good in another day or two because sometimes that happens and I hear about it. And the people that have contacted me to say that my dog was lame and I was worried and I made this appointment with the surgeon and then she or he is better now, but the surgeon says we should still do it. This is what happens also. It's like, no, you should not. Anyway, so mom and I just talked, and this is an updated photo of Nico. She never got the other TPLO. So are there other options? Yeah, some people get the tibial tuberosity enhancement. That looks fairly gnarly there, does it not? And from Canada, Danny Anderson, one of our great and popular and knowledgeable and beautiful people with our courses, she just recently sent me this, and this is post tibial transposition. And many non-boarded surgeons who just love surgery do it all the time and are performing them still. Because I asked, well, aren't TPLOs like not happening now in Canada because of the COVID thing? And she said, well, these still are still going on. And then she's seeing the post-ops, which have many complications. Is it the procedure or is it lack of skill? Because, as I said, when they don't have quite as much surgical training, then their results are going to be different. Here from veterinary surgery in 2013, so tibial, not transposition, tibial tuberosity advancement, TTA. Here they compared the long-term, so greater than 1 year outcomes with respect to function and complications in dogs undergoing tightrope, which is an extracapsular approach, and TPLO, and the TTA for cranial cruciate ligament disease. If we just jump to the end, long-term outcomes for the TPLO and the tightrope were superior to the TTA based on subjective client and vet assessments. Each technique was associated with a high long-term success rate as they're measuring it. So they're getting feedback from whatever, with the tightrope showing the highest safety to efficacy ratio. So a note about how people are assessing outcomes is I think that they are not being trained to look and to palpate well enough and astutely enough, because I know that, again, when I've been in close approximation to surgical practices, and I hear or saw people checking out, and the surgeon would say, "Wow, he looks great. Look at how good he's walking." And I'm like, "Oh, that dog is in pain. That dog is lame." So I think that there's a fair amount, and you might think differently, but I think there's a lot of convincing the client that, boy, this dog is a real success, because why might not a person be invested? I mean, I wouldn't try to mislead anybody, but I just think you start palpating that dog, you're gonna find some more information. So realize that many preventive and treatment options exist other than surgery. So, and if we do nothing to change things, nothing will change. And I find that this situation needs to be changed. And costly, painful, and highly invasive approaches will continue to be sold to clients when these clients might have opted to select integrative medicine and rehabilitation first if informed about them. No wonder so many veterinarians are depressed, burnt out, or bored with conventional medical approaches. There's so much more to learn, to perform, and to offer to clients and patients. And then, without risking having to recommend euthanasia because the negative outcomes were too upsetting, costly, or painful for clients to keep trying. So it's a happier way to practice medicine. As this little guy says, there's really no need to rush into surgery, and you don't have to rush into a TPLO. So about the complications in even more, beyond inflammation and infection, there are perioperative complications. Let's see, have you heard about these? Do you know about these? If you're a vet, do you talk about these when you might even refer for a TPLO? Significant hemorrhage from cutting into an artery, debris from sponges at my beloved Pez Anserina's, and then having a soft tissue foreign body reaction, infection, draining tracts, swelling, bruising, seromas, broken hardware, drill bits, screws, holding pins, screws in the joints, jig pin in the joint, and then also damaging the meniscus. If it wasn't damaged before, it might be damaged after the surgery that you are so wonderful. That's great. Oh no, this dog had a meniscal injury. What a bad dog that is. I don't know how that happened, but that's that dog's fault. Or maybe you, as the client, you did something wrong. You exercised this dog too quickly. Continued injury of the cranial cruciate, which has not been attended to. You've just been reformatting bones, or injury to the caudal cruciate ligament because you've been really like changing things, changing the anatomy. Vascular compromise to the patellar tendon, avulsion of the tibial tuberosity, torsional deformities, implant failure. How does that make you feel when you have all these clients? Yeah, they're not all going to be 100% bad outcomes, but there's enough pain out there that I couldn't do that. Risk of TPLO postoperative, chronic pain and lameness, patellar luxation, again, infection, fractures, implant failures. You got to take the plate out, as we saw with Nico. Other bones fracturing, slow healing osteotomy requiring a bone graft. Who pays for these things when they happen? The client. And now, as if that wasn't enough, the pivot shift. And here's a link to video on the post TPLO pivot shift with suspected caudal cruciate ligament tear. Oh, a twofer after TPLO surgery. Um, and then a case report of surgical management. Yeah, if nothing else happens, just get them back into surgery. We'll fix that. So if you don't have another surgery for the first TPLO, this is where you've been told to expect and start saving for your dog's second TPLO, because nothing they're doing is going to help the tissues unless they're recommending rehab and a whole new thing. But when you have the mechanics so off like that, and you are sensitizing the nervous systems, the central and peripheral especially, that other cruciate and that whole system, the hips and the knees and the back and everything, they're under a lot of different types of stress. So yeah, you might need to be saving for another one. If you're not going to change something that you're doing, then nothing else is going to change. And we see chronic tissue changes in these animals. Their mechanics are not right. They do not return to normal. You have changed the anatomy and the conformation, the configuration of this dog. How can you expect the range of motion to be the same and normal? It is never going to be normal. So T, P, pain, and lameness. Here's a study, it's open access from Finland, and showing that, this common situation, assuming that it's cruciate ligament rupture and all that. And you have surgery because that's what's so common and everything, that the average long-term dynamic and static weight bearing of the surgically treated limbs, yeah, okay, that returned to the level of healthy limbs, but how were they evaluating these these studies? And if you just go there, then okay, yeah, that looks good. And the surgeon in my class that was waiting for me to ask questions, and they come at me and they say, well, such and such studied this and such and blah blah blah. And it's like, okay, but look at this. However, extension and flexion angles of the surgically treated stifles remained inferior to healthy joints, and impairment of active range of motion and weakness in thrust from the ground in the surgically treated limb was frequently present. And so I know from doing research for herbs with dogs with multiple limb lameness, and we did force plate analysis, it's near to impossible to interpret that data because there's so much compensation. You've got back pain, you've got multiple limbs just varying their forces. It's really hard. And then here in the study, they looked at the long-term assessment of cruciate repair with pain. And they found that there was not only a decreased weight bearing in the surgically treated limb, likely not only reflecting the functional outcome, but also pain in the surgically treated limb, because when they're lame, they are typically painful. Moreover, in the orthopedic examination, lameness was seen in almost 20% of these dogs long term, and the pain response on flexion and or extension of the surgically treated stifle joint, there was a pain response in a third of dogs. Okay? So you, so anyways, a third of dogs are still having pain. Was it worth all that you went through to get there with the TPLO? I'm supportive of extracapsular repair, but not supportive of TPLO. And we should be looking at conservative non-surgical approaches before anyways. Oh, and then there's this. Oh, TPLO. Oh, TPLO. Oh, osteosarcoma from 2018. And this is after, all right, yeah. I mean, when I started seeing case reports of osteosarc and I started mentioning this to my colleagues, it's like, no, no, it's just one. Okay. Well, thank you for the study. Association of tibial plateau leveling osteotomy with proximal tibial osteosarcoma in dogs. 40 times as likely to develop proximal tibial osteosarcoma if you have a TPLO versus you don't have a TPLO. How many clients are told that before they sign the consent form? Post-surgical pain, we talked about that. People get it too. Gnarly scars, and that's not only on the surface, that goes deep. So you've got pain, you've got cancer, you've got lameness. Why not try non-invasive options first? What would be the harm? Prevent, educate our clients about early neutering issues, provide proper nutrition, tell them how to exercise and not exercise their dog, keep them at a good weight. Cranial cruciate rupture is not inevitable. We have structures that can support it, can support the limb, and help things recover. We can get in there. We can encourage sensory motor control over joint stability using the hardware and the software with medical acupuncture and related techniques. We can help those muscles activate. We can use thoughtful integrative rehabilitation and exercise and stretching. We think back to the proprioception that is delivered from the pes anserinus superficialis and how it is so important at spleen 9 to keep that joint strong and under control and not cut. So acupuncture, photomedicine, each has its own fortes and there's lots of overlap. Medical massage, she's almost really touching that pes anserinus. She might be caressing it and sending it just loving thoughts so that it does its job really well every day. And then exercise therapy, and we think about that iliopsoas, we think about the back. It's the whole dog. It's the nose to the tail and the top to the toes. So a lot of people ask about bracing, and when I get vet students that come through the acupuncture course and I ask them, what do you think about bracing? Oh no, oh, it could cause all kinds of problems. Well, we need to get in there and get some good braces, use the ones that we have, make the most of them. Results indicate high owner satisfaction rates for bracing as well as, okay, they were convinced the TPLO was good too, but that, that was how they talked to me. Owners considering non-surgical management with an orthosis should be advised about potential complications. Yes, okay, fine, you have to say that, but give them the opportunity to have a brace. So all in all, we have, and I will address questions. I see some here quickly, but all in all, we've talked about a number of ways to directly treat the problems. What is TPLO doing? It's treating a non-problem, really. I mean, it's like assuming, okay, we're going to cut the whole top off the mountain and then it'll be nice and flat there. But what could have been done for each of those tissues that participate in leg, knee stability and motion and flexibility and resilience that can be brought to bear to keep that animal whole? So it's time to turn this thing around. Let's look at some questions. How is the pes anserminus affected by the medial buttress? Great question, Deanna. I suppose it's moved a little bit, and I would suppose it might be stretched a little bit, but that medial buttress forms over time. So I think there's probably some compensation, but probably that pes anserinus is like, buttress, will you stop that? And I realize your problem. Or maybe the pes anserinus and the nerves is like, calcium, wherever you are out there, come and lay down here because we need to get a better surface here and a stronger, plateau here so that we want to avoid the TPLO, but we can have a nice stable joint over time. So it might be an accomplice. So we don't really know, but I would think there could be a potential for some added tenderness, but we can evaluate that, and that would be a great thing in our courses to really intentionally explore and kind of see, okay, is there medial buttress? Is there tenderness at the pes anserinus? So awesome question. You always ask such great questions because you know so much. Do braces promote laxity of the supported structures? That's a great question too, because I think that's what we are taught to think. And like you see people walking around from their chiropractor that have like a neck brace. I think if you rely on that too much, then then your muscles, I mean, if it was really supporting you or with the brace, I think there's a risk there, but I think what's more important at the beginning is to provide that stability so that you're not continually re-injuring things and intermittently be working with your strengthening exercises, your assisted standing, the things that the client would learn to do with rehab, but that because at times when I have not been diligent enough about keeping my own muscles intact and my knee gets too loose, then I mean, to the extent that I even bought 5 different canes a few months ago because I buy everything like multiples, but, because I wanted one in my car and everything, because I was actually using a cane to get around, it was that bad, and it was massage and specific, and I would show them, look, it's this long head of the biceps femoris, and I would show them where, and eventually we got it to where it was right, but it was muscles being too loose, it was muscles being too tight in areas, just throwing off the biomechanics, and so in those situations, I mean, I have braced my leg and I loved the fact that I didn't have to be fearful of too much motion. So I think there's a good way to use braces. And those dang dogs, they have funny shaped limbs, so they don't stay on so good. But we have, a lot of different ones, some that go over the back so that they will stay up better. So again, I think that they should be definitely explored with the client. And just one of my main things is when we learn in school that, oh no, that won't work, they really need surgery. And yeah, there's various rewards for people that won't allow thoughts of other things, and maybe they genuinely think it's not good, but we need to have more of a voice, and we need to have a multiplicity of brace options that are out there and have them in our practices and show the clients other dogs that have them or other videos or pictures and give them options. So that's a great question, and thank you for raising that. Dr. Robinson, what points would you use for treating suspected torn cruciate? Oh, Very wonderful question there. Yeah, well, if I wasn't a critical thinking medical acupuncturist, I would say stomach 36, stomach 34, spleen 9, spleen 10, and then everybody could write that down, or I could just do it mindlessly and maybe attach some e-stim, and maybe it would work or maybe it wouldn't. But that's not the point. The point of being a medical acupuncturist with a strong scientific basis is that we are going to palpate. So, number one, is it a cruciate? So, what are we finding there? Are we finding swelling? Are we finding tenderness to palpation at the joint line, especially? Where in the whole animal are there myofascial strains? From where to where? Long patterns outside of the stifle. What is, if you're treating lameness, what is causing the lameness? What is causing the pain? What is causing movement restriction? What is causing insufficient strength, insufficient flexibility? So ideally, we don't go with recipe points, but we go with what the dog's body is telling us from a good myofascial exam, what our eyes are seeing with a gait analysis. And I mean, those are your two best things. I don't stress out over the cranial cruciate draw, any of those typical cruciate tests. They make me kind of shudder because I've seen people holding dogs down, 3 people holding a dog down, and dogs laying on the floor, and the examiner is moving back and forth. It's like that dog is worse when they leave the hospital than when they came in. That is not necessary to do. If somebody wanted to give me an anterior draw test, they'd probably find me, positive or whatever. It's like there's so much more to finding pathology of structure and movement in that cruciate than forcing that joint. I actually have had patients or clients that say, I will never go back there again to that service because of what they did to my dog. That was a lot of people actually said that. But also that, and it's not just at one place, it's various places, but also a physical therapist that had worked for about an hour on this one dog that finally, yeah, I think there's finally some movement here. I mean, when you have tunnel vision to the extent that you can only accept whether, it's like, I don't know what to think if I don't say, is it lax or is it not lax? It's like that, you're so missing the boat. So we can do a lot better, and that's why I am presenting what I am to you, and I am available for questions if you want to contact me, narda@curacore.org. Feel free to yell at me if you're a surgeon. We can get into it. I don't care. You can go to the website if you're a client. We have curacore.org/vet. That's the vet side of our website. And then on there, you will see Find a Practitioner. And this is where we have people that have graduated from the Medical Acupuncture for Veterinarians program. But we're also having rehab courses now, too. And so many of our MAV grads are also taking our rehabilitation courses. And that's a little bit about what it was. There's so much to say about the cruciate. We actually had a multi-day course on it last year, but now this year we're expanding it into other joints and a neurologic part as well. So the good news is that out of CSU May 2019, I ran across this news story: surgery is not the only solution. Veterinary orthopedic service is expanding treatment options. Surgery is not the only solution. Ta-da! That's good. Okay, get out there, examine closely, examine well, take your time. We can do this. See you next time.